Okay, thank you, everybody. Thank you for attending this webinar. I congratulate you that even if in this difficult times with strange circumstances, you are still interested in dental education and in the future of dentistry. Now, let's begin. So I hope that you are now awake after the lunch break. I don't know what have been told you about myself. I'm a general practitioner working in a dental clinic in a small city in Germany. I am since 30 years in the profession, and I'm infected by the virus of digital dentistry as yourself also. And I am riding as yourself on the wave of the new technologies in our clinic. We started to implement aspects or technologies of digital dentistry already beginning with, 10 years ago. And we see now that this is actually the dentistry which we have to do today. It's not even the tomorrow, it's the today. And it is a discipline which needs new parameters, new coordinates, new validations of the technologies which are coming very fast on the market in order for us clinicians to be able to implement those technologies predictably in our clinics, and also to implement those technologies in a coherent workflow in a way that there is a high precision, trueness, and accuracy of the data of the technologies, but also of the transposition or transmission of the data from one technology to the others in this workflow which we are doing lately. So technologies makes the world a new place and dentistry a new profession. As I said, we need new parameters, new coordinates. And that is why my first part of the lecture would be, and I hope you will not fall asleep in that darkness where I can see in the room, that about the literature-based, literature, and there's also a couple of cases which are at the base of or validating the technologies. And then we will continue after questions and break to only clinical cases where I will illustrate the digital workflow which we apply day by day in our clinics, the way really we do it. So why do we go to digital dentistry? This is the result of our striving to more predictability, reproducibility. We would like to have more minimally invasive procedure, more secure procedure for the patients, even to give them a better before visualize and better aesthetics and also predictable aesthetics, which the patient can see from the beginning on. Also a perfect comfort from the beginning on in terms of immediate placement, immediate loading procedures, stability and function on the long run. So that means we have to take from outside, from the market, and also from the technologies which are really developing very fast, the method which we see that makes our workflow more predictable, more fast, more aesthetics. And I give you an example. For example, I am focusing in my clinic myself more on implant surgery and aesthetic restorations and full arch mainly. But of course, we do also restorations only on natural teeth. And here is a method of minimally invasive guided preparation of natural teeth, just as an example of application of the digital dentistry in conservative treatments. That started actually with an article which was wrote by an Asian group, which was describing a clinical protocol of microscopic minimally invasive tooth preparations and a restoration or preparation through a guide plate. I have to move this away. So everything starts, of course, with a digital acquiring of the data, and I will go later on through the systematic workflow of all this digital data acquiring. But on this example is a personalized digital design of the smile based on the digital acquiring of the data. We really want to have a virtual library of the teeth and not a plaster model, not plaster models. So because we can work properly with and fast with those data, we can do, with the help of actual softwares, a visualization digitally of the future smile, future design of the smile. And then matching the visualized smile, the future shape of the teeth, with the actual one, we can see through subtraction and the amount of the tooth substance which we have to remove. Now, how do we remove that in a guided way, not by freehand? So then, by visualizing all the surfaces, the next part of the software will virtually plan a guide which is guiding us the movement of the preparation in a way that we definitely remove from the teeth only the parts which are necessary. So sometimes is only an shaping of the teeth, sometimes is nothing, sometimes is a little bit more, but that is the way we assure that we remove only what is necessary. Now, this preparation will be done in advance. So the veneers which we do will be prepared in advance, and the guided preparation will be done in the same session of the insertions of the veneers. So based on all kind of digital data acquirement and manipulation and matching and visualization of the digital data, we are able to offer this patient a beautiful smile in one session, whereas the first session is really only a digital planning based on the digital data acquiring, based on scanning the teeth and planning virtually the future teeth. So that is how, even on natural teeth, we can go and we can already reach the target which we saw at the first page: reproducibility, predictability, fast treatment, aesthetic treatment, and minimally invasive treatment. So that is why we document also in articles which we publish about all this procedure which we do on natural teeth. And this is an article of one of our DDS ambassadors, Jamil Gardi from UK. Now, the Digital Dentistry Society, which is the society which is the most scientific one, is doing a lot of research, providing the data of validation and the parameters necessary to utilize the technologies. So I will highly recommend you to join this international digital society to be up to date with all the data. Now, as I said, myself is an oral surgeon, and I started with surgery actually 30 years ago, and I was doing like 25 years only a freehand, so-called freehand navigation. That means mental navigation, as you do probably also. Now, today and in the last 10 years, we work guided also in implant dentistry. We are practicing in 90%. I mean, in our offices, I don't do any surgeries freehand anymore. Everything is guided. Depending if I use a static navigation with surgical templates, which are different kinds, and I will show you a couple of them in the second part of the lecture, and or a dynamic navigation, which works with a stereoscopic camera, all based on digital data acquirement and matching. Yeah. So when we talk about static navigation, meaning navigation with a guide, which is made ahead of the time, we talk about 4 chapters of treatment: scan, plan, make, done. The scan is the acquiring of all the digital data, and I will show you what that means. The plan means planning the smile, planning all the parts which are necessary for the surgery and for the initial prosthetics in order to be materialized. So it will be a visualized digital planning, which will be materialized by milling, printing, procedure, and so on. So a little bit similar to what we saw before in the conservative dentistry. Make is the phase where we manufacture all the virtual parts which we visualize. And done is the surgery, where we go to the surgery, and this is actually the first patient, really long session for the patient, where we use all the parts which were manufactured, and we use them in order to place the implants in a right aesthetic and prosthetic position, and also load those implants immediately by application of the provisional, which was milled or printed in advance. So this is the new workflow, which we introduced a couple of years ago already. And I have to say that with every implementation which happens in the technology today, which happens really almost overnight, and that is why we are so thankful for the technologies, we are validating them and applying and changing the workflow immediately and offer the patient an even more minimally invasive and more advantageous treatment for him, which is actually our main target, right? The satisfaction of the patient. So you can see here all the phases of the scanning phase, of the scanning chapter. It is the photography, which can be very different depending on the software and on the way we will visualize the smile. Also, videos are very helpful because we need to see the exposure of the teeth, the mimic of the patient, and also the smile line in different position of the smile. This is we talk today about facial aesthetic, and all the smile design is based on a facial aesthetic. We are not looking at the teeth only or at the mouth only. We're looking at the full face, and this in movement. And this is why the sensibilization of the technician is very important, and the relationship of the doctor with the technician is a very, very tight one, more than ever. These two people of the team, and actually including the assistant, which is assisting the surgery, are a very strong team which have to speak the same language and to have the same informations. And that is why digital dentistry is more than ever a team approach. Now, of course, as we said, we scan today the data of the teeth with intraoral scanners. And this is this technology started a couple of years ago and matured and became more and more precise, true, and accurate, and now is actually state of the art. Actually, if we do plaster models and so on, we are actually way behind, and everybody is going to a pure digital workflow. Now, of course, we need for the planning of the implants, the DICOM data acquiring, the cone beam CT, which has to have certain properties, which we will talk about in a couple of minutes. And by matching those intraoral scan data with the DICOM data, you will see the base for planning the implants. Now, of course, we were talking about the face of the patient. So how do we match the face of the patient with all the data which are behind the face of the patient, which are different kinds of data? So that is where the technologies are offering us face scanners, and most of the technologies are trying and succeeding to implement more technologies in the same workflow in order to help the doctor to match these things, or to transmit from one device to the other, where accuracy is lost, can be lost, or data precision can be lost from one device to the other. So we have today cone beam CTs which are offering a face scanner at the same time, and possibilities of matching them automatically or semi-automatically or manually. And also intraoral scan, which can be uploaded in the same software, and also the same software is offering the planning features of the implant. So all in one technologies, and this is what I would advise you to choose from the market, the technologies which are offering you one solution or all solution in one device, since they have overbridged all this transposition and are from the workflow point of view and from the handling point of view the most convenient. So other things, of course, a lab scanner. Sometimes we need a lab scanner. An occlusal analysis, we will talk about that also. It's mainly important to check the occlusion and to prove and to adjust the occlusion on the long run on implants with the sensor-based technologies, with some technologies which are much more precise and need to be much more precise than the blue paper. And this is also adding value to the precision and the long-term function and stability of our construction. And also movement registration. After we acquire the intraoral scan data, we upload it in a software you will see in a couple of minutes, in order to register then the movement of the jaws, which can be registered and transposed to the next steps of the treatment. But let's move forward. Now, as I said, the pictures has to be very accurate, and it's not only for lectures, it's for the technicians to see the patient, even if he's not in the same building, and do the photographies which are meant to be necessary for the software, for the smile visualization software, which you really want do. And we have in the title the word artificial intelligence, and this is, you are right, the artificial intelligence technology is the one which is at the base of very many softwares which we don't even think about that it is in the dental field, in the medical field, in the dental field. And it will be more and more at the same, and I will share with you more of that also at the end of this lecture. But what is artificial intelligence? This is a technology which started actually and came out in 1955, and people realized that you have to move to these new technologies. Nevertheless, because of the many burdens and and expensiveness of this technology, it became or it started an AI winter where 20 years didn't happen anything. So the definition was made by John McCarthy in 55 as the ability of a computer program to think and learn. The first computer which was famous was based on artificial intelligence and working on artificial intelligence was Deep Blue, in 97 beaten Kasparov with a system of 3 search algorithms. Now, that was then until as 20 years later, Stockfish was the computer which learned all the chess procedures, and it was the champion, world champion in chess. Now, in 2017, so not so long ago, Google AlphaZero, which was doing a machine learning, so it was learning from its own experience, was using, instead of 70 million calculation per second, only 80,000 calculation per second, and beaten Stockfish didn't lose even once by using his own experience, and even the first movement was different, using much more creative solutions than the Stockfish. So that means that a machine learning is one of the branches of artificial intelligence, which is learning from its own experience and is actually allow a computer to program and to automatically improve through its own experience. So I'm just mentioning that in order to understand what is coming and what is at the base of many of the features of the technologies which we have, because artificial intelligence is already now in healthcare, in patient management, in research, in treatment plan, in image-guided surgery, in image recognition features of the technologies, as you will see later on, prosthetic, orthodontics, and so on. So here are only a couple of examples of the softwares in dentistry which are already using the artificial intelligence. One is using radiographic images and image recognition features for caries detection. All the Invisalign technologies are based on artificial intelligence by using algorithms and statistical analysis and predicting the future outcome. Of course, structure segmentation and data conversion into STL files, which is present, is used now by many softwares of cone beam CT and so on. You will see later on. Also, margin detection of the preparation line, or also of the margin of the abutment, and I will show you in a couple of articles later on, is also using artificial intelligence. So, also the most modern devices which are used today and which are, for example, the cone beam CT technologies, which is target is to offer and very, very precise data. We know that the less or the lack of accuracy is coming first from the positioning, for the lack of the positioning of the patient or wrong positioning of the patient, but also of the movement of the patient. So an immobile positioning of the patient is important. This is what you have to look after at the devices that you acquire. Yeah, and also properties of artificial intelligence by tracing the lines, the anatomical lines are used in this new technologies. What we need, as I mentioned, from the cone beam CTs is a high image accuracy. So that is why positioning of the patient and the anatomic marking landscape is important to have it in this software in order to have the reproducibility. Then multiple fields of view, so you have to be flexible, low dose capacities, and I predict you that the 3D images will be the one which will replace completely the 2D images, since we work 3D, so we definitely cannot use the 2D images for a surgery, for predicting bone grafting, for predicting the surgery itself. As I said, secure patient positioning, more information in the same technology. So this is what you need to look for. So have that there in this device, the intraoral scan, the data of the cone beam CT, and even the face scanner in order to be able to match it fast. And also to plan this case in the same device, in the same workflow, on the same chair without moving from one place to the other. So when you look to a software, you have to have features which allows you to go through segments of the structures, and not only to have the 3D image of it, but also the images in order to be able to measure the length of the future implant, the width of the bone, in every perspective, not only one directionally, but also in a diagonal part. Then you need to have the possibility, or if it's possible, after the acquiring of the cone beam data, to acquire the face scan of the patient, which should be able, in order not to have to match other face scans with this image, or you look for different methods, you can have the possibility to match this face scanner, which is a completely different data as the DICOM data, with a semi-automatic way, or also semi-automatic way, or also manual way. Both methods should be able to be shown by the software. You have to be able to see the structures and to implement a transparency of the face in order to see if the positioning is right, or to add your own manual points in order to match these two structures. In this way, we can see the patient in the same technology without using a 2D photo. Also, through different cooperations of the technologies, we have the possibility to plan the software or to plan the implant in the same software. And planning has to be prosthetic driven. So in the same technology, we are able to match the STL file with a DICOM file and be able to plan in the same technology, either in the same or exported in this matched way, the STL or the PLI data, and go for the planning in another software, which is even more sophisticated. So you have these choices, you have this cooperation and those linkings between the data acquirement, the matching, and the planning in a smooth and predictable way without a big learning curve. Now, back to intraoral scan. There are a couple of them out there in the market, and we are judging this and choosing our technologies by criteria of trueness, precision, and accuracy, where the trueness and precision added give us the accuracy. And why do we need to have this digital data? There are the tools for the communication, for the to have virtual models. This is the base for our guided surgery. If we work with guided surgery, for the preparation of CAD/CAM, we are able to scan bodies, so to go really pure digitally in our workflow, and to have, at the end of the day, almost a pure virtual patient, which actually we aim to, if the precision, trueness, and accuracy is there. Now, probably the ones of you which are experienced, they know that we have studies which are showing the trueness, precision, and accuracy in single tooth, but or short spans of the bridges, and that the data of the acquiring, or the digital data of a full arch reconstructions or a full arch scan seems to be less accurate in all the technologies, in all the intraoral scans possible. Nevertheless, I will show you how and which are the criteria, and how do we, and which are the actual data and actual information about the trueness and accuracy of the scanners, and also how do we manage which are the parameters which we know and which we don't know to scan a full arch reconstruction, right? Because we don't want to do learning curves, so have a big learning curves. So with an with an intraoral scan, we are able to scan soft tissues, teeth. We have to take the scan, and probably the ones of you which are experienced, you know exactly how to scan, how to deal with it. It's a delegable technology and learnable technologies. The acquiring of this digital data is really a couple of minutes, and we need to scan for a digital planning and for complete data a lot of the soft tissue and vestibulum of the patient in order to be able to match. This is something that we need to know. All the tricks I will show you in the phase of matching. Now, of course, just an example of how is implemented all this technology in giving the patient an veneer reconstruction by matching the STL file of the scan with the face scan, acquiring all the other data in a dynamic and a static way, of course, both, and then in a static way. Then doing a smile design in a planning software, for example, ExoCAD or ExoPlan when we talk about surgery. This time is again a conservative treatment. And we have the prediction of this treatment. And then we can go for the walks-up, which the patient can visualize or materialize the virtual one. And this is the base for the milling of the final restoration, as you saw at the first case. Now, the accuracy of iOS is depending on many factors, and we just recently had a consensus conference on accuracy of the devices, and a lot of data will come out, and some of them I will present you today, but a lot of data will come out in the future. Because the accuracy of iOS is depending not only on the technology behind it, but also has to be considered the scanning strategy, the properties and the height of the scan bodies, using also the type and the material of that scan body, but also auxiliary devices which we use in order to connect maybe some scan bodies, which especially in full arch reconstructions. And this is one of the articles which came out in like a couple of months ago, also by by a group from the Digital Society, about a continuous scan strategy, where Mario Imburgia made this couple of cases with titanium scan bodies with a certain profile and a certain height, and used the intraoral scan to scan these full arches in a splinted way by flexible, by a resin. So, and he realized that at the end of and the evaluation of the prosthetic reconstruction, the precision of the reconstruction was very high, the success rate was very high, and we didn't encounter the same problems as without this continuous scan strategy, which is a novel technique. So that would be an addition, let's say, hint for you to scan an intraoral arch with a guarantee of a higher precision. Also, very precise and very, let's say, detailed studies are delivering of also another group of ours with Francesco Mangano and Oleg Admakin. We checked the congruence between meshes and library files, and we realized that there are incongruences between meshes with the same intraoral scanner, but also between meshes and library files. Based on that reality, we did an accuracy, and this is actually the widest study about intraoral scanners, a comparative one also with Francesco Mangano, Vigandas Rutkunas, and Carlo Mangano, where it was the scanners were compared by mesh to mesh and scan body to scan by nerve to nerve, actually. And we evaluated the trueness, the precision, and the accuracy, which is the added trueness and precision. By the trueness investigated in the study, by a model with 6 scan bodies, we saw that the Carestream 36 and 3700 had the best results, and by the mesh to mesh method, which is much more eloquent, and also very, very good results by the nerves method. So that is one of the, the widest comparison trueness study made on intraoral scanners. Now, concerning artificial intelligence in fixed prosthodontics, and I won't bore you very much about studies anymore. It's not coming very much more, but we have to go through that to see what is the technology about and what is capable the technology to do and which technology we should use. So artificial intelligence, as I mentioned, is present also in the prosthetic CAD/CAM softwares. So by uploading the intraoral scans of the jaws and of the provisional hybrid abutment, we can model the provisional crown, and it will be stored the way the provisional abutment and the provisional crown will be stored in a certain drawer in the software. Now, when we scan the position of the hybrid abutment in the mouth, after the healing, through the AI mechanism, the software is able to recall this file from the certain compartment of that certain patient and superimpose it with the scan done. And more than that, is able to trace the line of the abutment independent if the gingiva grows on the top of it. So this is a study which shows this property, and that means the technician, this is giving us the opportunity to do a pure digital workflow without printing the model, doing the crown out of the mouth. We use the same provisional hybrid abutment for the final crown, and we are able to do an perfect full digital workflow with a mean deviation of 44 microns which is absolutely acceptable. So the consensus conference pronounced the 50 microns maximum of lack of accuracy of the prosthetic reconstruction. So this is what you have to follow in your workflows in the office, and not the 200 microns which we're doing before. Now, scan, we saw now all the scanning of the digital data and the properties which they have to have, and also if we can have more technologies of digital data or more digital data in the same technology. Now we have to plan. So all this virtual data will be matched, as well as the intraoral scan of the initial situation, the intraoral scan or the visualized future smile with the DICOM data in the same technology or not. And this is the base to plan what? To plan the implants, to plan the bone grafting, if you want, to plan the future provisional prosthetic restoration, to plan the surgical guide, and all this will be done by a virtual software. Yeah? So, planning the smile, the future smile, it will be done with different softwares, and you have different softwares out there, beginning with a Keynote, which was promoting by Christian Coachman, to the DSD app, or even EvoSmile, which is an artificial intelligence based software to visualize the length, the width of the teeth, the color of the teeth. You can really choose what you want and see this in the movement of the patient. Let's give and see that in the movement of the patient. So this is a very cool smile design software too. Now the intraoral scan, as I mentioned, will be uploaded in this planning software. Yeah, not only the static data of the cone beam CT and so on. This data we are able to register the virtual movement and to keep the virtual movement. Now this technology is using an accurate intraoral scan. So as I said, it has to be a good technology behind it. And we are able in this software to implement also the occlusal vertical dimension without distortion of the CMD. I mean, when you open it in ExoCAD or in any other CAD/CAM software is wrong. This implementation of the occlusal vertical dimension is occurs in this software. And what is good about this in full arch reconstruction, because this is my main topic, is that we don't need any bite registration. We don't need any Facebook registration. This is all there, and the movements, which is also a Facebook is always a burden, especially when you work in full anesthesia, right? So, and this movement can be transposed, can be moved into the provision, into the smile design, into the virtual smile design software, into the building of the provisional, into building of the final. So it's this movement. If it's physiologic, it is to be placed and to be transported and to the end. So we've never had that possibility before. Okay, we planned everything. Now we go to make. So all this virtual data, which we plan for the guide and for the provisional, will be milled or printed depending on the technology which you implemented, and we will talk about that soon. So to do the guides and to do the provisional. Now we know that the quality and the accuracy of a printer is the condition to have an accurate guide. So that is why there are deviations with a very initial and very old, actually old, a couple of years old study. It shows that the deviation, the apical deviation can go until 4 millimeters. This is not permitted. So that is why we check the accuracy of all these devices and also the printers in order to minimize the lack of accuracy which can happen. So another article which came out also this year about the DDS seemed to be very productive in the validation. So the desktop printers in dentistry, in comparison, we took 6 different printers and made a comparison concerning linear measurements, amplitude, and diameter measurements. And we had the result that Form 2 was actually the most accurate in these terms. But another conclusion of the study was that actually the printers have a quite reliable accuracy with this ranking, which I showed you before. But the models, the printed models, have an distortion after 1 month of storing. So that means that the printed models cannot be reused because of the properties of the material which is printed and which is undergo some dimensional contractions over time. So when we go to that, workflow, to the digital workflow, I have this workflow, as I mentioned, it will be always implemented and improved depending on which technologies I implement in my workflow. So I have my workflow for single tooth, for full arch, for implants and teeth, and or only for implants, and all the team, all the 3 technicians, all the 3 parts of the team, I mean technician, assistant, and myself, are aware of this workflow. So it's no confusion, it's no happening. Because on the other hand, all the treatments are very individual. Every patient is individual. So you can encounter differences and individualities, and you have to focus on those. That is why the more the workflow coherent, predictable, you don't have to take care about it, and it's a self-understood procedure, then the more you can rely on that, and the more you can focus on the different individualities of that situation. So we did a complete study about complete arch fixed reconstruction in guided surgery and immediate loading. It's a retrospective clinical study on 12 patients with a 1-year follow-up. And the conclusion of this study is that we had, out of 72 fixed prosthetic reconstructions, a high success rate. Immediate placement, immediate loading is a very established procedure if you respect some parameters, which we will talk about in a minute. But what about the aesthetic success? Of course, we were doing immediate loading since the beginning on as far as myself. I learned and I grew up with this concept through to my mentors, and I did immediate placement, immediate loading from the very beginning. But due to the digital dentistry and the predictability of the result, are we able to deliver a better aesthetic success, a more predictable aesthetic success? And are we able to establish some parameters of digital planning in order to have a more predictable aesthetic success in the digital workflow? This is my question. And not only the success rate of the procedure is important, which we have also in the freehand surgery, but also the aesthetic parameter, aesthetic success of the parameters. That is why, as in this retrospective study, we realized in the study that we have some parameters which we respected in the planning of the implants, meaning a certain thickness of the bone, a certain thickness of the soft tissue, actually a certain added value of the thickness of the bone and the soft tissue laterally, or also in the depth. The depth of the insertion has to have a certain dimension by adding the soft tissue and the bone dimension together. And this algorithm should be added number 4. This was a preliminary conclusion from our study over this 12 cases, which I will show you right now. And then we started a prospective study, which is also continuing now. We're just working on it. in order to evaluate this parameter and trace the conclusion of this algorithm or other algorithms which are necessary to be set in a planning of the implants in a digitally planning. Now, for example, it's not only full arch. I don't really have single teeth or single teeth. I don't know why. Every office has a main patient group. But in this case, this patient had a missing lateral situation, and she came very unsatisfied, wanting a perfect smile. So how do we proceed? Now, of course, this is an interdisciplinary case where we took our orthodontist and asked him to open the side for the missing laterals and to give us the place for placing the implants in the lateral zone, which he did. Now, we also know that when we are opening the missing lateral part, and also generally the region of the bone is there very, very thin. So we need in the first row to graft those cases. But what we do before is a smile design of the patient. For that, we will take a scan. We will do then a virtual walks-up, and this will be the base of our grafting of the bone and grafting of the soft tissue if it's necessary, and of the final restoration. Now, I mentioned that the digital dentistry has to be minimally invasive. So no matter what surgical procedure we use, we rethink our initial and our traditional surgical procedures, and we focus to more minimally invasive incisions and also methods of grafting and of doing surgery which are more minimally invasive, because sometimes we go flapless, sometimes when we want to go more predictable and more minimally invasive, that is why we take the surgery also the same way. So if we have we know that in aesthetic zone, when we talk about aesthetics, because this is actually what the patients wants to have. If we talk about aesthetic, we know that we don't have to have vertical releasing incision in the frontal area, because vertical releasing incisions will leave scars after 1 year in 77% of the cases. Now, we also don't want to do an intersulcular incision, because we know that it has a recession mesially and distally of almost 1/2 millimeter. So in an aesthetic zone is a compromise. That is why we use, as in the middle, you can see a hybrid incision going with a papilla, being a papilla sparing incision, and intrasulculary going intrasulculary, having the good thing from the both worlds and assuring that we don't have scars and also we don't have recessions. But the first thing what we do with this incision is not the implant placement, is really the bone grafting. So this is the aspect then of the tissue after the bone grafting. You can see that's just a slightly scarce. So the intraoral scan and the visualized or the 3D virtual walks-up will be matched with a cone beam CT. And this is the base of a prosthetic-driven planning, as you saw at a couple of minutes ago at the beginning of the lecture. So we place the implant in a perfect aesthetic position, respecting, you can see the bone grafting here in the lower part, right? And we need that amount of bone, because otherwise we couldn't have placed any implant. So we respect the planning dimensions. We also plan the guide of the case, and also the provisional. So then we go for the surgery. And in thin bony situation, I advise you not to rely on the guide. As I always say, is a surgical guide, not a god. It has to be still a little bit open and looked for the position of the implant and insert it out of control. I advise you to do that in thin and highly aesthetic, demanding anatomic situations. What I advise you to do is also to probe the side when you are in anatomic situation which are near to the nerve or to important anatomical structures which you don't want to damage. So you probe with an implant probe, because it's not a God, it's a surgical guide, and the responsible for your planning is yourself and not the technician who planned. So the planning of the implants is occurring in a teamwork with a planner, which is the technician, on a prosthetic-driven way, but the responsibility is taken by you as a doctor. So that is why you know, and also the technician need to know the aesthetic parameters which has to be applied. And as I said, this is also a preliminary result and prospective study about the total distance of the soft tissue, total parameter of the soft and bone at the color of the implant laterally, and the depth of the implant, that means added soft tissue plus bony situation, has to be around 4 millimeters. And this is what we used here. So you can see that respecting those parameters, you have a very nice situation of the soft tissue. We use also growth factors, and using the digital data of the patient, we go for the final restoration in a CAD-CAM, virtual CAD-CAM procedure. And this CAD-CAM, of course, not only of the 2 teeth, but also of the frontal teeth, because we plan also, we did also a small crown lengthening. And we check also through an intraoral scan after 1 year of treatment, we see and match it with the implant situation, we see that this parameter is constant, is stable. So that is the conclusion, that if we have this 4 millimeters, then the volume of the structures around implants will not decrease, will not change. So volume stability means what? Means aesthetic stability, and also stability itself of the construction. If you don't lose bone and soft tissue, you don't have aesthetic compromises, but don't have functional compromises, and you have a stability of the implant on the long run. This is a young patient. We need to give those patients a long-term stability. We give in our office a 20 years guarantee. Now I give only 15 because I'm getting older, but after respecting some conditions, which I will talk about in the second part of the lecture. So, but in order to maintain it, we have to reestablish those structures and to have some parameters which assure us a stability of the structures on the long run, which is number 4 in this case. So this is the final aspect of the patient, and she's actually very, very happy about the result. She used to have a gummy smile, which is still there, but it's a very nice harmony of the smile. Now, another young girl, which was in treatment since she was a kid, and she had an accident. She lost the frontal teeth. Fortunately, it was more a soft tissue damage than a bone damage, but you can see on the left part, on the left side, the smile is generally not harmonious. The smile line is negative. So we have to actually work on the whole jaw, of course not in a very young age, but later on. So this is following this patient through the years. We gave her what she needed at the end of the day. And the first, we did a soft connective tissue graft in this region by taking connective tissue graft from the palate and place it. And after the connective tissue graft, you see we have plenty of tissue there. And doing again a scan of the situation, this is the base for doing the final restoration. Actually, first the implant, and then with the provisionals, and then the final restoration on this teeth later on. So by placing it digitally, placing that digitally, you can see that is a perfect positioning. no freehand placement is that precise than the guided and the digitally placed implant or a guided surgery. And this is already, as I showed you before, a guarantee for a good aesthetic outcome. The positioning of the implants, the perfect positioning, is a condition for a perfect aesthetic outcome, because we know that every mismatch of the positioning, every half of a millimeter, will compromise the prosthetic result. So also a combination, as you can see, through the soft tissue surgery, guided surgery, and also a very anatomic designed abutment, if it's cemented or screw retained, I will talk about that later on, and an S-shape concavity, S-shape form of the emergence profile is the way to go, is all parameters which we have to add in order to have a good aesthetic result, which looks like this. At the end of the day, the prosthetic was done by Stefano Inglese, and the girl is now, I think, 10, 15 years later, still happy with her result, and it's a perfect symmetry of the implant and of the natural tooth. And this is what we aim to reach also in single tooth restoration, so you can see the difference of the smile line, the difference of the shape, and yeah, the happy patient. Now, when we have full arch reconstructions, then we have a completely different workflow. I will go a little bit through one kind of hybrid case, and then to a full arch case as a standard case, whereas after the break, we will go to many cases, many full arch cases with many different aspects and individualities. So this young lady has also a disastrous situation of the teeth, and she really wants a nice smile since she looks really great. And we do also intraoral photos, and looking into the radiography, the teeth in the frontal area are not to be kept, and it will be, and also the lower gaps will be replaced by implants. We start with a smile design digitally, and in this case, we'll do also a dynamic registration of the movements after the uploading of the initial intraoral scans. This will give us the perfect situation of the bite, the face bow, virtual face bow, and also we are able, as I mentioned, to increase the occlusal vertical dimension according to the necessities of the virtual walks up, and move and keep this movement along all the workflow. Right? This is the walks up. Also, the face scan of the patient can be matched in order to see then the aspect of the walks up and in its movements. And then by matching all this data, we use, as you can see, we use different planning softwares like SMOB, Excel, Plan, 3Shape sometimes. Whereas I was outsourcing the planning before, now I'm doing the planning in my own office because my technicians are learning, and this is what I would wish you to do also, to learn together with the technician. And we plan the implants accordingly. You see, you have to trace the nerve first, as in any software, and then to place the implant with a secureness zone of 2 millimeters away from the implant, since we know that even if in all the workflow, a deviation of 1 millimeter can occur. Okay, for the upper jaw, same procedure, an aesthetic, prosthetic-driven planning of the implants. And then we go to make, of course, after the virtual data was planned of the guide, we go to materialize the guide and of the models by printing procedures, as you can see here. And the guides will be manufactured in a sleeved guide procedure, but we will see after the break also other procedures. The provisional will be done in a screw-retained manner. And then after the surgery, we, let me see, where are we? Of course, you get the protocol of the implant placement, because as I said, and you have to sign that protocol that you take the whole responsibility. Some software has the good feature to show you also the bone density in order to have a good idea about the primary stability of the implant in that case. And this is the provisional. In the same, this was a study not a study patient, and a course patient. There are a couple of them on the road. And then afterwards, we did on CAD/CAM re-establishment of the smile in a same manner. Sometimes we need to take also the premolars in a minimally invasive preparation manner, and in order to re-establish the whole smile. We don't do any compromises of the smiles. Of course, it's the wish of the patient how far we go with the planning, but we have to do at first a smile design, a walks-up, a mock-up, in order to see what would be necessary and find the right way, which is also wished by the patient, right? So, and this is the final result. Unfortunately, I have final picture of her, but it is coming, I promise you, in the next lecture I have. So, now, this lady is a cosmetician. She's 32 and she has a very severe perio disease. She's really very unhappy about her situation, and we try to give her the best solution ever. This was the case which we learned a lot about the workflow and about aesthetic parameters. So actually is the case which was documented in the article mentioned before. So when we'll see, and this is and that is what I showed you, it is an older case, and this is what the question is always: what would you do in such situation? Which are the teeth which you should extract? Which are the teeth which should keep? Which is the criteria of maintenance of the teeth? Which is the consensus between a periodontist and an implantologist in order to give this patient a long-term stability, function, and aesthetics. So a consensus would be, so I mentioned before, we give a 20 years guarantee of for our reconstructions if the patient comes every 4 months to control. I will mention that later on. But for that, we have to keep from the patients only the teeth which have 20 years prognosis based on studies and your own experience. Also teeth which have 10 years prognosis endodontically and periodontically will be kept, because after 10 years you can remove one tooth, replace it with another implant, but the construction itself will last long time. But we don't, when we treat the whole patient as a functional unity and in a prognosis, for a long-term prognosis, you never keep the teeth which have a worse prognosis than 5, or a shorter prognosis than 5 years. So this is a concept which we use in order to be a synergetic win-win for the patient on the long run. He won't be happy to come after 5 years and have a new work done with the same amount of surgery and financial issues. Now, which is the consensus between a periodontist as an implantologist? So they're referring to this case and referring generally. Actually, the criteria is not the infection and not the mobility of the teeth. The conclusion or the parameter is the remaining vertical bone height. Why? Because after 1 year of treatment, if after 1 year of periodontal treatment, the teeth are still infected and mobile, and we have bone loss coming even more, so the vertical bone height is less than 8 millimeters, then the tooth should be extracted and replaced with an implant, because otherwise we will have much more invasive treatment in the future with vertical bone grafting and more graftings and more unpredictability in order to give the patient an aesthetic result. So this is the criteria. And based on this criteria, let's go back. And so we had to extract all the upper teeth, and in the lower teeth, we treated, of course, periodontally 7 teeth, which had good prognosis for 20 years, and we extracted the rest. So this was our treatment plan. Now, of course, we do a functional or digital occlusal analysis at the beginning, because we need to see if the patient has some occlusal adjustment to do. And afterwards, we do an intraoral scan. Now, this sensor-based occlusal adjustment will follow our workflow from the beginning, through the immediate loading, to the also provisional, to the final restoration. We do again an adjustment, sensor-based. I will describe it in a minute. And also once a year, when the patient comes for recall, he comes every 4 months, but once a year we do then a digital registration or adjustment of the bite, because the bite is the one, or the overloading is one of the causes of peri-implantitis, and also of complications like screw loosenings, chippings, and so on. Okay? Tell me, are you still awake, everybody? You don't have to answer, but I have to wake you up, because yeah, we soon have a break, but I have to go with you through this case, right? Okay. So this case was done with a digital wax-up and real wax-up, yeah. And this wax-up was at that time scanned with a lab scanner. Smile Design was scanned with a lab scanner, but the digital data was the beginning of the planning, of the virtual planning of the implants. Of course, we have softwares to show the patient what kind of treatment she will get. So we get in the upper jaw a single teeth restorations in the frontal area, which I always aim to do, and in the lateral small bridges in the lower jaw. We will keep 7 teeth, as you can see, which was treated periodontally, and the rest of the implants will be set. So this is the treatment plan. If I would be in the room with you, I would discuss with you different treatment plannings, but since we go that way, you know, we can discuss in the break. Now, this is the base of the planning, matching the digital data of the wax-up plus the cone beam CT, and we plan the implants. This is the moment where you choose your implant system, your abutment system, or if it's multi-unit, or if it's cemented or screw retained. You plan actually mentally the surgery. You already have in your mind how you do, when you do your sinus elevation, where do you do your incisions, when do you have to remove the guide, how do you support the guide. And generally, and you will see in the cases coming after, that we always prefer to have a tooth supported guide instead of soft tissue supported guide. That means we don't extract, we try to keep 2-3 teeth for the supporting the guide vertically, like in this case, the first premolar, the second premolar, and then extract it at the end, instead of extracting all the teeth and placing this guide with pins, because the precision, the accuracy of all the planning is, and actually of the surgery afterwards is higher when we support it with teeth. So again, there are in this moment algorithms to be set in terms of design, the position, the algorithm of 4 millimeter, as I saw before, how many implants you do, what kind of reconstructions you do all on 4 or on 6, you do tooth by tooth reconstruction, how do you do the grafting, you graft the gap, or you open the flap or not, what kind of navigation you do, what kind of guide with sleeves, without sleeves, and you will see later on, and what kind of prosthetic reconstruction you do, screw retain, which is to be preferred, and how the final prosthetic reconstruction will be conceived. For that, we need to be very confident about the procedures of immediate placement and immediate loading. You know that immediate placement is the immediate placement of the implant after the extraction of the socket. And this is a successful procedure. And the immediate loading is a successful procedure by implants placed in the extraction socket if you respect some parameters. And this is something that is not regarding digital dentistry, it's regarding implant dentistry generally. There's our rules which were already conceived and respected and formulated and documented in studies. And Dennis Tarnow formulated the immediate occlusal loading conditions. So, which are the conditions which an implant has to have to fulfill in order to be placed and loaded in an extraction socket? Initial stability, 3/4 of the implant surface should be covered by bone, the gap should be grafted, and a splinted provisional should be inserted, and the occlusion should be in harmony. So those 5 factors has to be fulfilled. Then you are successful in the immediate loading procedure. Not everybody is using the immediate loading procedure. Now we were talking about screw retained and cemented. What do you use? What do you prefer? And I'm sure if I would ask now in the room, it will be, of course, screw retained, because screw retained has no cement, rests in the sulcus, as Linkevicius used to teach us, because cement in the sulcus is one of the main causes of peri-implantitis. So, but Joseph Kahn shows us in one of his studies, that 80% of the anatomical situations are in a way that even if you plan the implant digitally, the screw by a straight abutment would come, or the straight screw and then only without multi-unit abutment will come out buccally, as you can see in the class 1. Now, in the class 3, in the class 1, the class 3 is only a couple of percent, 3% of the cases, you have anatomy where in the frontal area the screw is coming palatally, which is wished. So that, what does that mean? That means that either you use a multi-unit abutment for these cases, or you use untilted screw as canal for the screw systems which have that, or you cement. And to cement, I will share with you which conditions should be used. So back to our patient, we know that generally for a successful implant placement, we have necessary a bone of 2 millimeters and a soft tissue of 3 millimeters. So that goes into the direction of the 4 millimeter, which we need to aim. So, and that 2 millimeter bone has to be there, even if it is there, and then you don't have to open the flap, or you have to graft it outside or inside the socket. That were the preliminary conclusions and data which we knew, right? The soft tissue parameters also has to have a certain thickness, certain height, a certain papilla height, and a certain attached amount or width of the attached or keratinized gingiva. So what was that? Which were those dimensions? So in a situation where we have all these structures and soft tissue is nice, then we go flapless. So that is why in Azemina's case, this is the name of the patient, we also didn't open the flap because it's not necessary, because all the structure are there and you go minimally invasive. Yeah. But in generally, how much soft tissue do you need around implants for predictable stable aesthetics? Since we know that the biology is completely different around implants than around natural teeth. We don't have periodontal space. We have less blood supply. That is why the soft tissue will be different. We know that the bundle bone will disappear or not disappear, will be diminished after the extractions. We know that we have horizontal bone loss of until 63% and vertical bone loss after extraction of until 11%. And no implant placement will save the situation, especially if the tissue is thin. So many studies showing, and just mention a few of them, that you need that thick tissue biotype in order not to have any marginal recession. In the thick biotype, you can see 0.6. And that if you have thick biotype, you have a very little bone loss, like 0.2 millimeters. Whereas in thin tissue biotype, until 1.5. So that means that around implants, we need a certain thickness, as you saw in that single tooth case also, a certain thickness of the structures independent of the implant system. So you have you need a horizontal soft tissue thickness of more than 3 millimeters, and also another study showing the same. And even if the implant has a platform switching design, you will lose bone if the tissue is thin. So that means you need a thick tissue, and all the studies are going direction 3 to 4 millimeters. Now, and also the height of the soft tissue has to be accordingly. So here you see the 4 millimeter rule, which has to be established, a bony and a soft tissue situation. This height of the soft tissue is giving you on the top of it. That is why I emphasize on the soft tissue thickness too, instead of the bone thickness, is giving you the fuel or the volume necessary to build up and to design the papilla between implants. Also, John Coyce shows in that you need keratinized gingival round implant in order to conserve and to give that functional stability, that health of the tissues around implant. So all this has to be respected, no matter if you go digitally or freehand. But these conditions has to be respected even if you go flapless. Because you can see today very many cases of digital dentistry. Everybody goes in direction digital dentistry, and we punch the keratinized tissue out, and we don't have keratinized tissue around the implants, which is wrong. I mean, we have to focus now on aesthetics and digital at the same time, right? So that is why a height of the soft tissue is important between implants, especially if you have adjacent implant situations, to give you to respect these parameters to give you a nice result. So again, this is the Azamina's case, the patient's case. You don't open the flap if you have the parameters there, only if you don't have. Well, if you don't have, then you have to graft and implement the soft tissue quality by matrices which are having the property to implement the soft tissue quality. In single tooth, as you saw in that case, you use connective tissue graft. But in full arch, you have to use matrices or membranes. It's actually matrices, which are out there on the market, which have the property to implement the soft tissue quality. And this can be mucograft, mucoderm, and different matrices are more and more coming out on the market. And the study which we did within University of Frankfurt showed that different matrices are increasing differently the thickness of the soft tissue. So those are the methods which can be used by opening the flap, or also through a tunneling or envelope technique in order to increase or implement the soft tissue quality. Important, and you can see that in all recent lectures. This is an old study actually, but now it's the awareness of the clinician there that we need a certain thickness and height of the soft tissue. So actually, yeah, so since, okay, let's go. So the situation of the patient was that the 4 millimeter was respected, and that's why we had an perfect situation of the
of the soft tissue afterwards. So this parameter will be respected in the planning of the patient, right? So this is the surgery. I think we still have 5 minutes, and then we can go for a break, question and break. Let's see how we move on. So you can see I don't open the flap. I keep the second premolars for stabilizing the guide, because we know that tooth-supported guide is a much more predictable from the precision, from the accuracy point of view, as the soft tissue supported. And you go to the surgery. I'm sorry, it's a strange noise here. But the surgery is really unspectacular, but you can see the precise positioning of the implants in the socket. You never can go freehand that precise, right? You have, in that case of the sleeve-guided surgery, and you have trays for guided surgery. So this is a tool, or this is a set which you have to acquire in the sleeve-guided surgery. In some others, not. But in sleeve-guided surgery, you need a special tray with a special sequence of the drilling, which has to be respected, and the assistant has to be aware of it, to go very systematically through all the tray and all the sequences, and you see the precise positioning of the implant in the depth, in the distance to the buccal place. So those 4 millimeters are respected and planned, and by the guide respected accordingly. Also, the provisional was done in advance after the walks up, which we did, and an screw retained provisional will be done in advance, right? So, of course, we need to respect the form of the jaw, and this is also a take-home message for you. If you change the form of the arch, the overjet and overbite of the patient enormously, the patient will feel discomfort by the tongue, by the phonetics, and also by the aesthetics. So that is why this is, even if you do a walks up or digital walks up for a smile, a nice smile design, in a full arch, you have to respect and to keep the form of the ridge and the dimensions of the jaw in the reestablishment, in order not to have big changes at the end. So this is how the patient leaves the office after the surgery. So we have an immediate loading and the upper jaw. The implants which are in the sinus will be not loaded, and in the lower jaw you have unloading just of the teeth which were prepared intraoperatively. So this is the aspect of the provisional after 2 days. So you can see it's very fresh, and the patient is quite satisfied with her provisional. Nevertheless, I would say the teeth are a little bit too long. So in the final restoration, you have to correct it. Now, back to the adjustment. Now, you remember you have to have a balanced, harmonious occlusion by the provisional. This is mandatory for the success of the immediate loading by the provisional. And that is why we adjust the occlusion with this sensor-based device. And I will show you at the end of the case how we adjust and why it's so important to do it much more precise than the blue paper. So after 4 months, you have a healing of the soft tissue, and we can do the final reconstruction by scanning or by a real impression. So, sorry, that was the guides. Okay, so the design of the abutments has to be done in an S form shape. Now, this is a real impression, since at that time we didn't have really enough data. This is an older case to see to deliver an accurate intraoral scan over the whole full arch. Now, we do the impression over the multi-unit abutments, especially in systems which have a conical connection and more tapered conical connection. So we do the impression over the multi-unit abutments. And we do an impression or a scan over the implants, and a scan or an impression over the implants and over the provisional and implants. We match the two components, and this is the base, you see, impression over the implants, impression over the provisional, and matching the two, also changing a little bit the design of the provisional. This is the base for building up the final abutments individually. So the individual final abutments has, as I mentioned, and this was done by Uli Hauschild, which is also a board member, DDS, and a very, very experienced technician, an S-form shape of the emergence profile and anatomically made abutments, which is today state of the art. So we don't do any other abutments as that. And this is the situation after the insertion of the abutments. Now, another parameter which you have to keep in your mind is not only the distances between the implants, is the distances between the abutments. And you can see that sometimes technicians do mistakes if we don't communicate with the technician. So the rule is, I'll show you the situation of the final, yeah, in the mouth and in the model. The rule is you have to have 3 to 4 millimeters between the margins of the abutments in order to have a place for the papilla to grow in between, right? So we know that that the gingival papilla appearance is depending on the anatomy of the teeth, on the contact point level or length, on the crestal bone height, and interproximal gingival thickness. So in order to produce or to design a papilla, we have conditions which we can take care of. I mean, except of the height of the soft tissue, which I mentioned before, you have today, look at the left picture, instead of conventional design of implants without platform switching, today we have, what do we have? We have implants with platform switching design. We have concave profile of the running room. We have a height of the soft tissue. So all in one, we have much more supracrestal fibers, which we can design in between the final crowns. And the final crowns, look at the right picture, in the final crowns has to have a design where the contact point between the crowns is 42% of the intercoronary space. That means, like Tarnow used to say, and that means the contact point has to be physiologic, not up there in order not to kill the papilla. So you need more, you need height of the soft tissue, height of the intercrestal bone, which we have, and then we need that profile between the crowns in order to design the papilla. And so then we have 0.5 to 1 millimeter longer papilla than initially, than in the past, okay? So this is a philosophy to make more aesthetic crowns in adjacent situations. Here, the technologies are helping a lot. I mean, there are, as mentioned before, the artificial intelligence is able to localize the margin of the abutment and also to place the margin of the abutment in a very aesthetic way by measuring, by being able to measure the soft tissue thickness, right? And to the cementing or screw retained abutment, again, I re-emphasize is that in the reality that for a cemented reconstruction, now that is why, okay, that is why this is the situation of the patient in the model, and this is the situation in the mouth of the soft tissue and of the teeth, with the abutments underneath, respecting those conditions. And this was the situation of the patient before. And this is the situation today. I mean, after the treatment. So we will take this case after the break and show you the follow-up after 1 year. And all these cases which you see, or a couple of cases which you see here, will be shown that after the break in a digital workflow and different approaches. And now I hope you are ready for a coffee and for a small break. And we continue after, I think, 10 or 15 minutes, as the boss says.